if I were a perfect clinician and I had perfect patients that always tell me everything to my face, and if I always asked the right questions, then the metrics would only ever bear out what I knew in clinical practice. However, you know, many times there are unseen things, and we can, if we don't have information, we tend to churn medications, or what I see more commonly is sort of what I call the just a qualitative check the box approach, which is, okay, they've got depression, I put them on a starting dose of an SSRI, and so we have a very good medication sitting at a low to mid-range dose for 10 years.
Yep.
And the patient just keeps going with subsyndromal response, subsyndromal you know, functionality is marred, and we never get that patient the justice of an adequate trial, even of that initial drug. Sometimes we have a Ferrari in second gear and we complain it only goes 40 miles an hour because we're sitting at, you know, sertraline 25, fluoxetine 20, for instance. And so those are treatment decisions that are really, honestly, a little difficult to defend in today's world of metric-based care.
I like the way that you put it very accurately with the Ferrari example being in second gear. I would further go that many people have Ferraris that are eternally parked in their garages.
Yes.
And complain
Yeah.
that their car is slow, or
Yes.
You know, it's very interesting because Dr. Trivedi, your talk pointed out two pitfalls. The first is this kind of rapid switching before being able to adequately assess, is this really not going to work, or are we just throwing in the towel too early? And then this other element, which involves leaving patients on a medication for too long a time when that medication is actually not going to be effective because it's run its course. And clearly, being able to measure something consistently and accurately, along with educating clinicians and re-educating clinicians about the time course of how antidepressants work, is going to be very critical in helping improve the care that patients with depression receive.
Just one point I think that you make is wonderful, and that is the price of continuing some treatment for too long now is even higher, because we now, as you started the program with, we have many more new treatments available, so we should be considering those rather than staying with something that's not working.
There's not only a therapeutic price, right? Isn't there a biologic price? If we really believe the biologic model of affective disorders, don't we have good brain research in terms of functional MRI, in terms of volumetric MRI, that show us that there are brain changes to the substrate of the patient? And so I wouldn't contemplate leaving a diabetic with hyperglycemia for 15 years because I know that there are downstream adverse events that happen because of uncontrolled hyperglycemia. I'm convinced as a primary care clinician that depression is more like that than just psychodynamics, and that there is a brain substrate that honestly I'm responsible for as a steward of that patient's health to try to get them better as quickly as possible.